You know what a fomite is? Inanimate object that may contain the fungi. So do not share towels, shoes, combs and brushes that might have come from an infected person, okay? You may then pick it up from those inanimate objects. Very common to pick up ringworm or what, especially on the feet, which we call tinea pedis or athlete's foot, from wet, moist floor surfaces, maybe like a pool, surrounding areas, that kind of thing. Okay, so yes, you can inoculate yourself, but here's other pictures of tinea. Do you see this very faint rim of pink? It's rounded, kind of like scalloped borders. You have to look and recognize those small little details. This is not eczema. Eczema is not well demarcated. It kind of bleeds out into your normal skin. You can't see where it starts and stops. This has annular, arcuate, rimmed borders. And to recognize that, many times you don't need your KOH. You can treat empirically. Now here's someone that has it really pustular. And when it's more inflammatory like that, the tinea is usually coming from an animal or the soil. Do you see the scalloped little rounded borders on this buttock region? Okay? That's not eczema. That's not atopic dermatitis. We've seen a lot of referrals coming to us that have been treated like atopic dermatitis on a grown man on his buttock. I'm like, okay, pull down, let's see what you got. And he's got all these little scalloped little areas, rounded, you know, arcuate lesions. I'm like, okay. And if you see that on a man, especially, you tell them to, let's look at your groin, let's look at your feet. Because many times they have tinea cruis, they have the onychomycosis, tinea unguium, male fungus, and the tinea pedis. And so when you've got it in all different areas, and it's the same fungus, Trichophyton rubrum, we call it dermatophytosis. It's everywhere. And so at that point, creams are not going to get rid of all this. You got to give them oral medicine. And since toenails grow the slowest and you have to utilize the oral medication the longest, there we treat for the region that needs it the longest. So oral terbinafine, also known as Lamisil, that's what we give. And for toenails, you got to treat it for 90 days. It's 1 pill a day for 90 days. So you'll see the skin clear up in a week or two, but we want to go until we clear up all those nails. And it takes a good year to see new toenails grow out, but you only need 3 months of the medicine. So we just tell them, take the medicine. Once you're done, you'll start to see early signs of clearing near the cuticle as the nail kind of starts growing out. But usually 6 months later, we have them come back and their nails about halfway or almost completely clear. But look at those rims around the tinea cruis, okay? So this is not yeast. Yeast has satellite pustules. It's not as, it's a little more ill-defined, okay? But you can, when the word tinea in and of itself means dermatophyte. And so the next word to it is telling you where it's located. So if I say tinea, if I want you to say, how would you say it on the hand? It's tinea manum, M-A-N-U-M, manum. If it's of the groin, we say tinea cruis. If it's of the face, we say tinea facii. If it's of the scalp, it's tinea capitis, right? What do we see if you wanted to scrape? Where do you take it? You take the little scraping of scale from the rim. That's the active border. You don't go in the center. You take the KOH from the active border of keratin scale, which that's the stratum corneum that you're just removing. Drop 2 to 3 drops of 20% of potassium hydroxide, and you let it sit with a little cover slip. Many times we'll let it sit for 2 to 3 minutes or up to 5 minutes so that that KOH will break down the keratinocytes and spread things out a little more so that you can see. Do you see all these little lines traipsing everywhere? That's the hyphae. This is what we would call abundant, just floridly positive. Okay? So there's lots of different topicals that are out there. There are some that can treat both yeast and dermatophyte. So it's important to know certain ones may not be as great as others, but we use ketoconazole a lot. I like over-the-counter terbinafine. That's what Lamisil is. So it comes topical. It just only treats the dermatophyte. It won't treat yeast if you think yeast is the issue. But ketoconazole will treat both. And it's fungistatic. That means it will just inhibit the fungi. It doesn't really eradicate it, but it can be very helpful. Terbinafine is fungicidal for dermatophyte. So if I know it's a tinea, I like terbinafine. It's over the counter. Patients can use it. But if they have it all over the body, I say use the oral terbinafine. All right. There's some other ones here, Tinactin. You've heard of that one. It's dermatophyte only. Okay, and low prox as well. But systemically, terbinafine. And one thing, what about a pregnant woman? Which ones can you use? Terbinafine is category B, which is nice. So if a pregnant woman had tinea and you needed oral treatment or topical, you can use the topical or oral terbinafine. And it's weight-based, so there are some differences of when you have to cut down the amount. The normal adult dose is 250 milligrams daily. If you're doing it for toenails, it's 3 months. For fingernail, it's half that. So it is 6 weeks. 12 weeks versus 6 weeks. But Lamisil is found at Walmart. It's on the Target and Walmart $4 list. Well, that's real nice for patients. They don't even have to present their insurance card. So most of the time I tell them I'm sending it to whichever Walmart that's closest to where you live or whichever Target, whatever they say. And it's so much easier than going through their insurance. Okay, so remember Walmart and Target $4 lists are out there for a lot of medicines, blood pressure medicines, all sorts. Griseofulvin, a lot of pediatricians like to use this for the kiddos. It does come in a liquid form, but they have to take it with a fatty meal for absorption. It can cause some upset stomach, and if a person already has liver abnormalities, you want to not do that. All right, facial rash again. Kind of looks like perioral, but there's more flakiness. And this is seborrheic dermatitis. Have you all seen this before? Seborrheic, do you know what that word means? Oily. Sebum-like. Seborrhea is meaning you have lots of oiliness. So oily dermatitis, oily rash. So it's white to yellow, oily scales of the scalp, forehead. So it's the central region again, but your eyebrows can be flaky. You probably have colleagues here in the room that may have a little bit of that. It's very common. Flakiness in the eyebrows, flakiness around the alar creases, in the beard region. You can get it in the ears, behind the ears. It can be associated with atopic dermatitis, allergies. And those who are hospitalized, it's a stressful kind of reaction. So stress makes this worse. Flakiness, people get worse with that. Upper respiratory infections, they get flaky. and it's in the scalp too. So think of it as dandruff that has moved into the face. That's basically what it is. People call it dandruff of the scalp, but the main medical term is seborrheic dermatitis. And if you're hairy, men who have hair-bearing chests, abdomen, the scales can even extend into the chest area and be red and scaly. Okay? Here's just different pictures. And in babies, it can be really thick and yellowy adherent scales, and it's lovingly called cradle cap in babies. So it's, seborrheic dermatitis is just kind of like the adult version, or as kids get out of that, the medical term is seborrheic dermatitis. And in people of color, sometimes it's hard to see the redness and the pink scale. And so in people of color, remember I told you about their labile pigment cells? So inflammation many times either turns their skin dark, or it may stun the pigment cells. So in this particular disease, seborrheic dermatitis looks like light spots on the face. Light spots along the eyebrows. Light spots along the alar rim and nasolabial folds. And you might see, it almost may look, oh, is that a ringworm? I'm seeing a little ring there. And we can call it petaloid seborrheic dermatitis, like petals. But anyway, if it's in the beard region and it's making little light patches in their skin, it's seborrheic dermatitis. So you treat it the same way. Lots of dandruff shampoos that are over the counter. There's prescriptive strength ones. Ketoconazole, that's in your dandruff shampoo section, called Nizoral. All of the dandruff shampoos either contain ketoconazole, zinc, tar, salicylic acid, selenium, all of those. And we know that dandruff, especially in the scalp, can be itchy. So we'll have them use a little bit of clobetasol, or other cortisone solutions as a drip drop leave-in. That's very helpful. People of color, they may, especially a woman who has it, they don't want to put wet, if they have a straightened hairstyle, or maybe they have chemically processed hair that's not naturally straight, they may want to not use something of a wet liquid, which is gonna, kink up their hair. So they may want more of an oil or an ointment, lubricant base for their scalp. So you don't treat patients the same. It's all based on their preference or their needs or their hairstyles, hair care. Okay, so over the counter, there's a product that is over hydrocortisone 1%, and let me think about it. Scalpicin. Scalpicin is over the counter, and it's a liquid hydrocortisone 1%. So a lot of patients can start with that and see if that really helps the itch and the redness in their scalp. Over-the-counter hydrocortisone cream may be able to be used in the areas of the nose and face where they have the flaking and redness. Sometimes I'll have them use those dandruff shampoos where they're really flaky in the ears and behind the ears. Put it on a wet washcloth, squirt a little bit of that shampoo, dandruff shampoo, lather it up in the shower, and go ahead, get their beard all cleared up, their chest that has the scales. That can be very helpful. All right, pink rash, pityriasis rosea. You all seen that before? All right, so what's the first lesion that's larger and bigger? Called Harrell's patch. Yeah. So if you just see that alone before all the smaller little spots come up, if it's that alone, people get confused with ringworm, right? That tinea corporis, and we've seen a lot being treated as tinea corporis. Just know, tinea corporis itches, the dermatophyte rashes of the cutaneous skin, they itch like crazy. This is a reactive viral exanthem. Viral exanthems do not itch unless it's something atypical. And so that's one way to determine, okay, this didn't itch. Did you have some upper respiratory symptoms prior to? And so usually It is HHV7, so human herpes virus 7 associated. That's an association, okay? It usually comes in the spring and fall. So as we get closer into the fall time of the year here with school-age kids, we'll start to see it, okay, in the spring. So kind of school year time, you'll see it. It's non-pruritic, we just talked about that. So many times we just say, hey, let it take its course. It's not bothering you, it'll fade on time, but it can take 3 months. Sometimes it can take up to 12 weeks for the little patches, the little papules to fade, okay? All right, let's look at these more silvery scaled, well-demarcated plaques, known as psoriasis. And so they love extensor surfaces, elbows and knees, but we also see it in the scalp, we can see it on the trunk, and the nails can be involved too. And the silvery scales, do you see how white and silvery thicken? That's different than seborrheic dermatitis, right? The other was kind of yellowy, oily scales. This is heavy, thick, usually white scales. 2% of the population, they have psoriasis. And it affects males and females equally. And 5% will develop swollen joints and arthritis. Nails have what they call pitting, little dents, and so that's the psoriasis affecting the nail matrix and causes dropouts of the nail plate. Sometimes you can get a discoloration, a yellow-brown discoloration. It looks like fungus, but they call it oil spots. And many nails will start to lift up, and you see space underneath where the nail bed, the nail plate has separated from the nail bed, and they call that onycholysis. So we'll look at some. Here's other types of psoriasis where you can see how that can, my goodness, that looks like ringworm, doesn't it? Looks like tinea corporis. So, you know, sometimes it does require scraping of a KOH. But you have to look, is it including the scalp? Is there nail changes? So you have to look at the whole picture and try to slowly but surely peel away your differential diagnosis, okay? And what's more likely. So psoriasis has topical forms of corticosteroids that can be used, vitamin D, tar, tazarotene. Ooh, we saw that word before. That's a retinoid of a topical, right? That's the most effective retinoid cream and gels. Well, it also has FDA approval for psoriasis. It helps to peel those dead layers of plaques down. Oral medications, methotrexate, acitretin. When you're getting into these, it's time to send to a dermatologist, pretty much, okay? So you would probably only be working in the topical steroid version, which is the triamcinolones, the mid-potencies, and maybe high potencies like betamethasone and clobetasol. Those are used a lot. One thing that we do not like to use in psoriasis is systemic steroids. In injectable form or in oral prednisone or whatever form, do not use systemic steroids, avoid it in psoriasis. It may work while you're on it, but as soon as you get off of it, there's a potential for a horrendous flare and maybe even new psoriasis in areas that were never there before and can be pustular now. So there's a form of psoriasis called pustular psoriasis, and sometimes you can have this generalized eruption after you have stopped steroids and have a generalized pustular psoriasis form that many people have fever, they're sick, and they have to be hospitalized. So if you're working in an urgent care, don't do the quick and fast thing and inject them with a steroid, because we may see the effect of that in our office. Of course, we use a lot of the biologic agents that are out there now. Humira, Enbrel, which is adalimumab, and Etanercept, we have a lot of those, and we have to screen patients to see which ones are the best candidates for those that don't have other immunosuppressive things going on. Light therapy can be very helpful. Light therapy helps to decrease lymphocytes in the skin, so we use it for a lot of inflammatory generalized eruptions. Okay, but we do know that if you use light therapy, they say after about 200 exposures, especially in a fair-skinned person, it will increase your risk for skin cancer. It's kind of a double-edged sword, but we'll use it, and usually we don't ever reach that amount of exposure before we can get a response anyway. All right, scaly rash. Do you see that with eczema or atopic dermatitis compared to ringworm and psoriasis? These are kind of ill-defined patches. They're not well demarcated. They're just kind of hazy out there. So think of this as an eczematous dermatitis. There's several eczema. So atopic is under the umbrella of eczema. There's many eczematous processes. Atopic dermatitis, which is the young kids that can grow up to have it. But then there's also nummular eczema. Have you ever heard of that word, nummular? Nummular means coin-shaped. So adults usually, if they have eczema and maybe grow out of atopic, they get coin-shaped eczema a lot of times on their legs. You can have dyshydrotic eczema, have you heard of that? Where you have kind of an abnormal response to water, you're washing your hands a lot. And especially hands, they get kind of waterlogged, but then you start getting blisters along the sides of your fingers like tapioca pudding. Little vesicles everywhere, blisters, and you're like, ooh. And so it's usually found in those who wash their hands a lot, hot water, alcohol, chemical cleansers, things like that. That's dyshydrotic eczema. There's contact dermatitis, which is an eczematous thing. So poison ivy and all those, that's an eczematous dermatitis. This one's common. First year of life is when it usually appears, and it usually is diagnosed by the age of 5. By the age of 5, most atopics are diagnosed, and it's associated with allergic rhinitis, asthma, hyper IgE. Of course, there's a Th2 cell activation and mutations that are seen. So this is something that is genetic and can run in the family. So usually there's atopic family diathesis, as we call it. So we ask, who else in the family has atopic dermatitis? And they may not have that, but they may have the asthma. They may have, another person may have the allergic rhinitis or the dry skin. So flexural surfaces are the classic, behind the knees and the antecubital fossa. And in people of color, if they continue to scratch, what's going to happen to their pigment cells? They get disturbed, and with an eczema, they hyperpigment. So it can get really worse on them. Okay? Sometimes when your skin is so cracked and open from scratching, then you're more prone to infections, right? So many times we see impetiginized atopic dermatitis, so we have to treat with antibiotics in addition. Sometimes we see what's called eczema herpeticum. That means HSV infected eczema, eczema herpeticum. And so we see that in little kids a lot. Do y'all want to, let me finish this and we'll take a quick little break. Atopic dermatitis treatment, of course, are steroids topically, both topically and systemically many times are used. So this is one where, yes, you may have to use oral steroids, but corticosteroids topically, and it depends. So on the face, we don't use high potency steroids on the face. We like to use hydrocortisone. Now over the counter, it's 1%. You can find that. It becomes prescription strength at 2.5. Hydrocortisone becomes prescription strength at 2.5%. And so it comes in cream, it comes in ointments. We like the ointment-based products, especially in inflamed rashes, because it doesn't sting as much. White creams will sting on inflamed skin. And so we use ointments, which are Vaseline-based, lubricant, and so you can do the 2.5 hydrocortisone for facial things, and triamcinolone, 0.1% ointment, that's a mid-potency steroid. for the trunk and limbs, including the neck. And most of these things are twice a day, BID, dosing, very thinly. We'll use those. The pimecrolimus and tacrolimus, those help to reduce the inflammatory chemokines. They are non-steroid, which is nice. So they are also safe for the face. It's important to lube up. Hot water is not their friend. They can't take hot baths, hot showers, cool it down lukewarm. Gentle cleansers, nothing that's harsh, such as deodorant soaps. Nothing that's perfumed. So we like our sensitive skin Dove. There's some other products, and the Cetaphil and CeraVe products that are out there. Mupirocin is a prescriptive strength antibiotic ointment that's great for those that are impetiginized. Some little kids who are just covered head to toe with eczema, it's hard to kind of get a hold of it. So we'll either have them take a nighttime bath, get out, pat dry, and we'll put all their ointments on, face and trunk and limbs, and then get a onesie, have the mother have a onesie with feet, and they wet that completely under warm water, rinse it out, and they put the whole baby in the onesie. And then they put dry clothes, whether it's a button-up, little pajamas, or a dry onesie on top of that. And so that ointment then is in a humidified environment. It's going to soak into the cracked skin so much better. And we call that wet to dry wraps. And for kids who really have it really bad, we'll do that. If it's just their hands and feet, we'll do the same kind of thing with warm, wet socks and put them over their hands and feet, and then put a dry one on top and have them sleep like that. It really, especially those that are really getting where they've scratched to the point of thickening up, and we call that lichenification, where they've thickened up, it really helps. If oral is needed, many times we'll do tapers of prednisone, or dexamethasone. Prednisolone is one that we use too as well, I should say. Cyclosporin can be used, but we don't want to use it long term. Cellcept or mycophenolate mofetil, there's a lot of literature showing that is very helpful and is not as immunosuppressing as the cyclosporin or methotrexate. So we have been using a lot of Cellcept for chronic, severe atopic. So when you're at this stage for oral, it's time to refer to dermatology. Sometimes we have to use the oral antibiotics and acyclovir for the eczema herpeticum. And of course, light therapy helps this too. All right, let's look at brown things really quick. I'm going to have you take a break really about, where are we now with time? 2:30. 2:30? Okay, we're nearing the end. So do you all want to take a break, or are you all good? It's a lot of information, but I think that these are common things that you all will be seeing, so I'm sure it's going to stick pretty well for you. I don't mind waiting for a couple minutes if you like. Feel okay?